Hey, Jeff, how are you?
Doing well, thanks.
Good, man. Good to see you. Good to see you. So everybody's still coming over from the other room. So we'll give a couple seconds for that to happen. And Rob did a great job, obviously. And I expect you to hold the bar high as well, my friend.
But we're going to try. We're going to do our best. So I was talking to Stu, though. Worst comes to worst. If things go wrong, I'm just going to move my mouth and pretend that the audio's not working, and we'll be good.
That's it. No one will know the difference. I was like, why can't I hear him? Why can't I hear him? Good stuff. Good stuff. So I would like to introduce Jeff Lambert-Shemo. Jeff is a certified athletic trainer and director of sports medicine for NovaCare in Northern Ohio. I recently met Jeff, and I'm pretty confident in his presentation, and there's something to be gained here. So I'm going to turn it over to you.
Yeah. I don't need to share my screen yet, do I? I can just start talking first.
I mean, you could, or you could just make your introductions and then share your screen.
All right, yeah. So just so everybody knows, this is my first time on this platform, so it's a little bit interesting. So I'm going to do my best here. If you notice, I'm going to look around a lot because I have notes, computers, and everything, and I have my screen going on here. So, and if you lose me, it's because I'm probably walking over there because I got confused about something. But I'll make sure that I do my best to stay with you. Just one quick warning, I am not a linear thinker. And what I mean by that is I might be bouncing all over. I do have the slides. I might up on a different slide. I might go back and forth. That's just the way I work. In fact, my other clinicians, they love when I do evaluations because I have my patients on a table, on the floor, on the table, outside running. And we go all over the place based on where I'm at. So stick with me. We'll get to all the information, but it might not come through in the direction that you would think it would come. So I guess I'll go ahead, and if it's should I go ahead and share my screen and get going?
Yeah.
All right, I'm going to go do that, and we'll start chatting that way. Just like Rob was saying, this is the hardest part.
Yeah. Stu says his brain works the same way as yours.
Good. So everybody's going to be confused the whole time.
I know Stu, so.
Awesome. All right, I'm going to pop it up.
There we go. Awesome. All right, I'm out here. I'm available if you need me, but take it away, my friend.
All right, I'm going to start. Look, I even have a laser pointer up here. I don't know if you guys knew that. It's pretty fancy. So, a little bit more background just so that you know. I'm glad that I'm following Rob because we are totally on the same wavelength, but coming at it from different directions. And the nice part about that is you're going to be able to see a couple different sides of the way things can work. I'm looking today at practical application of functional testing to drive clinical care. What that means is it's what I do in the clinic. I actually have had the opportunity, and I'm going to show it a little bit. I do have the opportunity, or I have had the opportunity to have the digital product, and I'm going to show you what it looks like, how it works a little bit, give you some data. But the number one thing, into our topic, I look at function to resolve pain. Pain is commonly caused by improper movement as a result of asymmetries stemming from some kind of an initial event. Then what happens is, based on that event, the body adapts, and it adapts to the way it moves, and it finds a way to adapt its biomechanics to find a way to perform the activities of daily living it needs to perform, regardless of whether the form or the function are appropriate for long-term success. Commonly, that ends up in an unsustainable movement pattern that gets what ends up in chronic pain. An initial event, you can see we have a number of opportunities for initial events. It can be a myriad of sources. It can be an external event, Bart's throwing a hammer at his dad, getting struck, tripping, hitting your knee on something, obviously an external event that causes an injury. And from that injury, the body will adapt to move in order to maintain its movement and move forward. An internal event would be something where a sprained knee, or I should say like a chronic knee pain, patellar tendonitis, it's an internal event. It happened within the body due to movement. Again, the issue there is that the body will start adapting and moving differently in order to make sure that it can keep moving and performing its duties the best it can. This adaptation is where we're going to get in a little bit of trouble. Next, we can have a chemical stress. Chemical stress is probably more what you're seeing with your older clinics and your older patients. Chemical stress is going to be over time. Obvious ideas could be, like illicit drugs. Somebody has diet issues. Someone has even something as, carbon monoxide stress, but more commonly like a diet issue. So they're an unhealthy person. They're not moving. Their body goes into a fight or flight response because of the stress from their food diet and their food choices. Guess what? You have your hunched shoulders, your head down, and you start to get into that pattern where you see people walking around the grocery store, slumped down, moving around, can't move very well, moving into that fight flight response, and that fetal posture turns into a lot of pain, chronic pain. And lastly, psychological stress. And this is probably what we're seeing most in most of my clinics. And we're seeing back pain, shoulder pain, neck pain from the posture of sitting, looking at a computer, stress, getting that fetal posture, and not being able to get out of it. This is our issue with lack of exercise, lack of normal movement. So that initial event then, we have your adaptation. So the human body is built for two things. It's built for personal survival, and it's built for procreation. I'm just going to let you know that I'm an athletic trainer. Procreation is definitely not on topic today. We're not going to be hitting that today. We're going to talk more about survival and efficiency. Over time, the body will evolve by adapting to its surroundings and its individual struggles. So when the body hits injury, pain, and stress, it's going to find a way to move. That desire to survive is the body utilizing as little amount of energy as possible to perform its duties. So that's efficiency, working to achieve maximum productivity with minimum wasted effort. In the nervous system's eyes, what we're looking there is that the body's going to perform whatever function it wants to and it needs to, regardless of the healthiest and safest ways to protect me from injury, to protect itself from injury. So the easy example is picking something up off the floor. We all know the best way to pick something up off the floor, to do it safely. We're going to bend our knees, we're going to squat down, we're going to pick it well, we're going to protect our back. Something much dissimilar to this. Okay, right here, this is a good example about the most efficient way to work at something on the floor. Yes, reaching over, bending over, it's efficient. Use the least amount of muscles, least amount of movement, work on it, stand up. Over time, however, this is where we're going to be. We're going to be this little guy in red here. We're going to start having pain. And then, you know what? It's great for my workers' comp business in the clinic. So this movement pattern then is going to be obviously unsustainable over time because we're going to break down. So if an unsustainable movement pattern results in pain, that means that our pain is going to be a symptom of a dysfunction or a disease or an injury. So what is this dysfunction and how do we find it? So is the dysfunction from a current movement pattern or from a past movement pattern? So best example, patient walks into my office, they're complaining of foot pain, ankle pain, shoulder pain, it doesn't matter. I ask where the source of it is. They may have an event that is a current event. However, we can also look back. There may be a past event. So especially with this topic, we're going to talk about lower extremity. How do we find that event that's really responsible for the pain? So finding the source of dysfunction, when we're looking here, initially, there could have been a left ankle sprain. Who knows? 2 years ago, 3 years ago, resulted in a limp. That limp 2 years ago could have dispersed and not had an issue, and the patient could have been fine for 2 years. However, then there could have been a right hip flexor overuse possibility, left lumbar overuse. Next thing you know, 2 years later, the patient doesn't even know it, but they're coming in the door with right medial knee pain. Here's my question. If we treat the knee pain without addressing the rest of the issues, when and how will we get to a full pain-free activity? So the way I look at it, we'll end up fighting 4 injuries, one after another, unless we find that root cause. I use functional testing to find that root cause. And just so you know, side note here, I actually just threw this in this morning because I realized I didn't actually say it at any point, but pain is probably the worst predictor of the site of a dysfunction. And, we're going to figure that out. Now, I like to use technology when I utilize my testing, and there's a few reasons for it, but I'm going to show you, number one, why it was difficult for me. So most of us may be, using technology or trying technology or looking at technology. I'll be honest, it was really difficult for me at first. When I first started using technology, my ego got in the way. And my ego gets in the way once in a while still. My clinician's egos get in the way all the time. And the way I want to look at this is when I use technology to test function, I think to myself, wait, I have how many years of education? I did an undergraduate thesis, 1,500 hours of internship. I have a national certification, hundreds of hours of continuing education. I've had literally thousands of successful rehabilitations, youth, high school, collegiate, professional. I've had an opportunity. I've been pretty lucky. I've had an opportunity to work with a few Olympic athletes, specifically in the track and field area. And they've been successful. So why do I need this technology? Well, I figured out, but for my clinicians, I'm still trying to teach them. Two quotes that I get clinicians, and you may hear this from other people as well, is number one, why do I need a computer to tell me what I already know? That was actually a word for word. And then I have an email that I got with someone that said, okay, Geek Squad, because I wanted to touch somebody functionally with some technology. And he said, okay, Geek Squad, I'm not throwing my eval out the window for any computer programs, but I'll take any help we can get for this kid to wow a potential referral source. Gets a little difficult to try to run a program and try to increase when our clinicians aren't willing to move forward a little bit. So my goal is to show you how I have moved forward and what I utilize now. So functional testing with or without technology. Here's that ego thing coming in again. Functional testing of any kind is a fantastic move towards understanding a person's movement patterns. And it's a great way to find out how they're contributing to weakness in performance or pain. Watch somebody squat. You're going to get immediate information on glute strength, hamstring strength, flexibility, pelvic stability, calf flexibility, balance. When I watch a squat, what do I see and what do I address? What do I document? So the one issue with doing this testing without technology that I've found is even though I have the experience to understand the testing and it's time saving to do it quickly, I can have someone do 3 squats. I can say, oh, I think I know what's going on. It's still subjective there and it's generalized. And the reason I say that is because there's bias. When I don't use technology, when I don't use my cameras, when I don't use my systems, when someone moves, I automatically get a decision of how they're moving, and I start putting them into a group of where I have commonly seen patterns. And then all of a sudden, I extrapolate the data of what I see to find out what I want to find. And I put that patient into an area of what I want them to see and where I want them to be because I know what I want to treat. Well, the nice part is with technology, I get rid of that a little bit. I get more objective. When I test with technology, I get reproducible results. The system is unbiased. And my favorite phrase is beyond my eyes. So I'm able to test the person and get information that my eyes can't see. I'm looking beyond my eyes to find out how they're moving and what could be going wrong. To keep switching both back and forth because I have 2 systems going on at the same time. So what do I use? I have 2 main utilities, and I'm going to explain them quickly. I use the Digisole, and you'll see this on the left-hand side, and I use a Fusionetics platform. What a Fusionetics platform is, and this is my chart here, is it's pretty much it's a squat. It's about 15 squats. Sometimes I do upper body, sometimes I don't. In this case, I didn't really include the upper body, so it's zeroed out. But it's a system that allows me to objectify the squat that I see. The Digisole, I actually get to walk the person, and when they walk, I get to see exactly how their body moves. The reason I'm using both is because I'm constantly learning how the body moves and adjusts and adapts. To get a full picture of a person's biomechanics, I need to learn which inefficiencies are affecting foot biomechanics and which foot biomechanics may be affecting pelvic stability. The Fusion X platform that I use, and this is by no means an ad, it's just what I use because it's quick for me and I have experience with it. I have the opportunity to use their AI software or to perform the squat and enter in what I see in their faults manually. The nice part about the Digital, it is a footbed which moves with the body and tracks the body's natural movement. Rob mentioned a little bit about treadmills. I think the beauty of this system that I've used is it's not a treadmill-based system. I put the insole in the person's shoe and I walk them outside and I run them outside. Okay, so when they come in, I can download the activity and I can see how they move in their natural environment versus in the unnatural environment. I do have a manual treadmill in my office because I think it's a little bit better than a mechanized treadmill, but still, I definitely prefer outside. After I analyze, then I go ahead and I get to get a better map of the person's, their different adaptations. So what am I going to look for? When I'm testing, I'm looking for three main areas at this point. And again, since we're talking about gait, we'll focus on that. You're not going to see anything about shoulders and necks and heads today. The other thing, just so you know, we are talking about gait. I do very little gait analysis. What I do is I look at the body and see how it actually affects the gait. What I'm looking for in general, pelvis, knee, ankle. We're going to go into a little more detail here, but there are a number of different pelvic instability availabilities that you can see. The foot, supination, pronation, neutral, over and under pronation, and the knee. The thing is, right now, if you look, his pelvis, his hips have already turned. All of his power is going forward. The only thing the rest of his body has to do is expression of power. So this bat is going to be the expression of power come through. Power is created from the pelvis, balance, power, strength, everything begins with the pelvis. And then our feet, our hands, our shoulders, those are the expression of that strength. Okay? And we can actually come to running. If anybody here has heard of the pose method of running, this is what came there. It's a way to teach running. So it's where this comes from. So our pelvis is our center of mass. And I want you to try something if you can. It's hard to show because we're on Zoom, so you're going to do it on your own. If you have a cup, go ahead and put it in front of you. And what I'm going to show you is there's no way that we can move forward, back, sideways anyway. We can't do any lifting, any movement without our pelvis moving. It has to be in charge. So if I pick up my right foot, I'm totally balanced with the ground. I cannot move forward or to side. I can't move anyway until I break the balance of my pelvis to the ground. Okay, so if I'm standing on one leg, I'm doing it right now. You just can't tell. I'm balanced. If I take and I let myself lean to the side, now my pelvis moves. I had movement, and all I do is break my pelvis from the center of mass. Change my center of mass, broke it from gravity, move. Pelvis is involved, has to move before our body moves. Okay? I can't walk unless my pelvis moves the way it has to move. You want to see how it's also more important, put a cup in front of you. If you stand quietly on 2 feet, go ahead, just pick up your cup a little bit. You're going to feel activation all the way down your side. Okay? That activation goes to your pelvis because it has to create power. If you want to do something a little bit stronger, pick up your right foot, pick that up, and if it's heavy enough, you will feel your pelvis actually shift away from that cup. When you feel it shift, that shows that your pelvis is involved in every bit of creating power. There's a ripple effect. So that's the reason that I start there and I work out. Now I'm going to show you a little bit of a test. Great example here. This one, 14-year-old cross-country runner. I would normally have used someone else, but he just walked into my door a few days ago, so we're going to go with the young people just like Rob did. He had an MRI with a focused bone stress on his left medial distal tibia. Thought it was a shin splint. Actually, within 2 weeks, went from no pain to an actual focused bone stress point. No other history reported initially. I'm going to say that on purpose because there's a little secret coming up. If we look at him, this is putting him through a test. This is just a double leg squat. Okay? And my video is not going for some reason. There it goes. Here goes my video. So double leg squat, obviously we see a lot going on. We see a left hip shift. We see a right rotation. We see a right vagus movement with his right femur, his right knee. We see, if you look closely, I'll show you again, we see a little bit of a left foot pronation and a little bit of a right foot supination. He's static here, and you can still see it. Let's go back one more time. Oh, it's not letting me. That's okay. We'll go over to here. So when I go to the single leg squat, on the left side, we can look. This is his left single leg squat. As he's going, I want you to notice left foot, a little bit of pronation, a little bit of valgus here on his left knee. See if we can get this right one to go. There we go. Right one's going. One interesting thing is, this is my fault. His foot was hiding this. But if we look at his right side, we go back in, left foot moving all over the place. Can't control it. Interesting thing here is, now I'm going to take him, I'm going to walk him. When I walk him in this with this platform, I see one important thing. And even though you see all these values, the most important thing, which you can only tell if you've seen the person walk, is his shoes have a really high arch and they're really squishy. When he walks, he cannot get enough power and weight in his body to squish his shoe and squish the arch of his shoe down. So when he walks, this helps to, somebody asked earlier on Robert's talk about, looking at the shoes. Well, this is an opportunity to look at the shoes. When he walks, he is held in supination and he has no way to get out of it. So I'm glad that we saw him in walking. Now, if I take him, and this is another opportunity of walking, one thing that's interesting here is this system, it has a little bit of a way to decide where, based on the foot movement, where the power is most likely coming. So he had a left foot injury, left tibial injury. So he's not pushing at all off of his right leg. He's doing most of his work using his left hip by lifting his foot up instead of doing a nice, even, nice symmetric walking movement. Now we have running. So I ran him for 2 minutes. When we look, when his heel strike comes down, I see a little bit of a difference, but he's unloaded. But when he loads and he puts all of his weight on his shoes, he's got a nice little pronation on the left side, which, we talked about pronation a little bit, that it's just a movement. Pronation is actually shock absorbing. So I like to see a little bit of pronation. It's normal. It's shock absorbing. It's how one of the ways that your ankle helps control your shock absorption. But on his right side, he's got a little bit of a supination. Okay? Very different. So left side, little pronation, right side, little supination. Interesting here is, after I saw this, I just walked up to him. And when he came over, I said, "When did you hurt your hip?" It's exactly what I did. And guess what? He said, "About 2 to 3 weeks before my shin started hurting." This is, again, with running. We can see, you might not understand the grasp, but that's something we can learn later. But he definitely has a little bit of pronation with his left foot, and this shows his supination on his right foot. So he's definitely running away and staying away from that left foot. Here's where it gets a little bit more interesting. I'm going to start talking fast. It's already 4:15, but we're good. He is spending increased time on his left foot with his gait, but yet his right leg has a little bit more force going down. So his right foot, the way I'm looking at it, is this is actually his hip. His right hip has lost its ability to be a shock absorbing. So since it's not as shock absorbing, he's got a little heavier gait and heavier hit there. But he's spending a little more time on his left foot, and he's spending more time on his left foot to deal with that right foot problem. Okay. What's happened is, over time, his body, just over those 2 weeks, has found a new way to move to deal with his hip pain. Guess what? He adapted from his hip pain to be able to keep running. But when he adapted to be more efficient, to be able to keep moving, he adapted into into a movement pattern that was not able to be continued. So for driving clinical care for him, I removed pressure from the tibia. I return him to a less symmetric gait and a gradual return to run to minimize the opportunity for injury. That's the goal. How do I do that? I ignore his feet. I go with a hip, back, and glute program, a single leg balance program, and a bilateral low extremity strengthening program. It's nothing to do with his legs or his shins. Okay. In order to drive clinical care, the other thing I do, I'm going to show you some red flags. These are some other individuals. The gentleman that you see here actually owns a running store, and I tested him in a single leg squat just to see how he moves. Things in red flags and opportunities for correction when you look at runners and people with pain. If you see someone doing a squat and they have this little bit of a clawing foot, it's kind of hard to see. I can blow it up for you. But his left foot is nice and flat here. His right foot, he kind of overarches it and rolls it in there. I call it a clawing foot. That clawing foot often happens with a varus knee. And what it is, that's the foot controlling his balance versus his pelvis. He's had right hip flexor pain for a long time. That foot pain tends to go with same side hip complaints. Check on those foot flexors. Here they are right here. Your flexors of your foot, big toe and your feet. How do I correct that? Number one, I want to inhibit both of these muscles and activate the glutes, pelvis, and the pelvic stabilizers. By doing that, I can start to try to turn that person into a little bit better of a gait pattern, starting with walking well and then gait. What does that mean, inhibit versus activation? So in this case, if I see a hypertonic muscle, and that's going to be those foot flexors and that clawed foot, when I see those muscles, they're going to be in a state of contraction to control movement and control the body's balance instead of their normal function, which is going to be contracting and relaxing. Those sore muscles very commonly are mistaken as weak, thinking that they're fatigued, but they've actually lost their ability to contract and relax. They're just holding on tight. So I inhibit those, and then when I inhibit those by foam rolling, stretching, and my favorite is a low megahertz vibration. So I use a lot of tools. I use low speed tools that vibrate, foam rolls, a ball. I use my trigger point gun. That's my favorite one. Put it on low speed. The patients hate it because it doesn't feel good. They love it because they feel great afterwards. So the first thing I'm going to do is I'm going to inhibit those muscles that are overworking. As soon as they're inhibited and as soon as they're relaxed, then I go ahead and I switch over and I start activating the appropriate musculature. So I'm going to inhibit those ones that are working too hard in the lower body, and when I want to get the pelvis moving, I'm going to start with like some open chain or non-functional pelvis controlled exercises first. Clamshells, bridges, band walks, and I'm going to increase, and as I get stronger, I'm going to end up going into closed chain exercise activities with strength building. And again, once I build that basis of strength with those muscles that I found out that aren't working because of the adaptation that they did to become more efficient, now I can start pushing to function. But especially when I get into function, I'll have people that I bring them in, and I have to have them doing this inhibition activation before every run for sometimes weeks and months. So before they go for a run, they have to sit down, work on their calf, work on their foot flexors, if we're looking about this specifically, and then activate, do their clamshells, then they can go out and go for a run. And there's not a break for that. That takes a long time. Other red flags and opportunity for correction. If I see knee pain and distal IT band pain, very commonly I'm looking for the same side glutes that they're not working, or I'm looking for a late glute firing at the moment of mid-stance. So what that means is it might look like it works fine, but when their heel hits and when they get their full weight on it, we're going to get a late firing. So it's not going to fire in time. So then what's going to happen is your TFL and your hip flexor are going to contract, and they're going to try to control that femur because it's going to move too fast because the glutes aren't doing their job to control it. So they're going to try to slow it down. Guess what? We end up with your tendinitis, your IT band syndromes. Another one, and this is through this asymmetry. If I see an excess time in stance during a gait analysis, if they're on their left foot too much versus their right, sometimes you're going to look for a same-side weakness in the kinetic chain. But sometimes you're also going to realize that it might be taking longer for the neuromuscular system to calculate the weight, control, and stabilize the body before it can move on. That extra time is because of a same-side issue. Okay? But sometimes, and this is where you need the whole body, you have to look at the whole kinetic change, sometimes that longer stance is due to overloading to adapt because the other side is weak. So sometimes the pelvis, I might be running, and my pelvis might go left foot, middle, and my right foot is just barely touching the ground because there's something going on there. So all of a sudden, I'm overloading one side. So pelvis goes middle, left, middle, left, middle, left. Now I have the asymmetry there. So it could be either way. You have to watch. You have to look. That's the whole point of our functional testing. And then really quickly looking at the increased force like I was here. Commonly, just due to the inability of some other part of the lower extremity to absorb the shock of the body weight load in the foot. But again, could be overloading on one side because the opposite can't control the body weight. Talking fast, so hopefully that's enough information. Quickly go through athletic performance. I know I'm running over. I hope it's okay that I go 2 more minutes. The body is built for efficiency. So instead of just looking at injury, sometimes we want to look for performance. Athletic performance, since the body's built for efficiency, it always wants to use the least amount of energy to perform a task. That also gives the body less flexibility for error. So any variation from perfect form can result in overload or injury. The reason I bring that up is I use this testing to find any instabilities, any asymmetries, or any adaptations. If I have a baseball player who can just throw a ball forward and just hit, and the only place they're strong is in those 2 tasks, if they have any variation from form, that variation from form is going to go on a part of the body that isn't prepared, isn't strong, and isn't trained, and then it's going to result in some kind of an injury. So the goal of athletics, I don't want an efficient athlete. I want an athlete who's powerful, durable, and precision built. Okay, so I want to make sure I train the full athlete. So when I hear sports performance, most people are training sports performance and they're thinking, I want to get better at throwing a ball. No, for me, sports performance is I want to get better at throwing a ball even if I'm in the wrong form, if I'm in the wrong place, if I'm falling over. If I'm built for power, durability, and precision, I don't have to worry about getting injured during my skill. Last one, we're near the end now. When I'm looking at athletic performance, this is a great example of efficiency and why efficiency is actually a terrible word when it comes to the body in athletics. Landing with a valgus knee and jumping with a valgus knee, you know what that is? That's the body getting efficient. The body isn't strong enough to land with its body weight, isn't strong enough to jump, but it's going to find a way to make that movement happen because the goal of the movement outweighs the risk of the injury. Again, the body's only built for procreation and efficiency. It wants to survive. This is the way the body is surviving, by finding a way to move regardless. One last one, lower extremity kinematics. We should be about done. I think I only have like one more slide after this. I just took this yesterday. I just wanted to show how the body moves together. So when the body moves, my hips, knees, and ankles are generally one chain. I get supination, valgus, and hip external rotation at the same time, varus and external rotation. Add the hips in, guess what? Everything moves together. It's a pattern. These are patterns that we would expect to see with weaknesses. And if we follow these patterns, it's going to give you a little bit of a shortcut, but it's also going to give you a better opportunity to find out what's wrong with individuals. For me, the keys to success are finding the tools that work for me and my patient population. It can feel like it takes too much time to go through all this testing, but I'll tell you what, once you document and retest, the opportunity to make up for lost time is there because you're solving the person's problems a little bit faster. Any time with setup and testing, just so you know, at least in the U.S., setup and testing that you think you might be wasting time, it's billable. We're providing a service. You also get some nice patient and provider buy-in with recording and reporting. You know, that all looks pretty. One of the reasons I like to use tech. And then now I'm using my experience to analyze and create the programs versus using my ability to do my best at figuring out how to test someone. I now get to just change. Instead of testing and doing my best to test, I let something else test and I analyze the data. And then I assess each test individually and I learn exponentially. Keys to the most effective recovery. The more specific you can get on your testing, the more adaptation information you can get results in better specific exercises. The more specific your testing is, the less exercises you need to recover. if you can minimize the number of exercises, you can maximize the opportunity for recover because you're going to really focus in there. Retesting validates or invalidates your rehab programs. Find out if you're doing it the right way. And sometimes just, a retest might look worse as muscles begin to retrain and begin to move away from adaptations. So you might have an ability that you can shut down somebody's IT band, shut down their lumbar to get their glute medius working correctly again and their piriformis working correctly again. You know what? It's going to start working. Their strength is going to come down in your chest. So the goal is now when they're working appropriately, their strength can start climbing up. My goal is I keep learning with my patients and I keep pushing tech to work for me. I know I went over by a few minutes, but hopefully we're going to be okay with that. And
Absolutely.
We got all done.
Stop sharing.
I just stopped, didn't I? Let's see. Here we go.
Yep. There you go. Cool. Awesome. Hey, great information. You picked up right where you left off. For the most part, I think we're still pretty much on schedule. I expect Stu to talk a little quick. You know how they do in the UK. They go real fast. So he'll make up some time. And the reality is, it's all good. So I really enjoyed the presentation, and it looks like the attendees did as well. So I'm going to stop streaming. Everybody, go back to the when we stop streaming, just go into the next room. We'll see you there with Stu Campbell. All right, Jeff. Nice job.
Thank you.